Sir, we are going live in 5 seconds. 5, 4, 3, 2, 1. Sir, we are live now.
So thank you very much. Good morning, everyone. Welcome to the Fellows Academic Module. And the next three Saturday sessions are scheduled to have hip preservation module. And I have asked my dear friend Dr. Mandar to take responsibility and organize this. And Dr. Mandar will moderate all these three sessions in coming week. Welcome, Mandar, and thank you. Thanks, Dr. Avi, Dr. Prasad, and Dr. Aditya Daftary for taking out your time and be part of this informative module. Mandar, all yours, please go ahead.
Yeah, thank you, Maulin, for inviting me for this these three sessions. So what we have planned is three sessions of various topics in hip preservation. As we know, hip preservation is a topic which has come up in the last 15 to 20 years, and it is basically a method to salvage the native hip into as good as possible and to make it last as long as possible. And what we'll be doing is today we'll be discussing about the basics of hip preservation, right? Starting right from the clinical examination, the basic X-ray findings of adolescent hip pathologies, and going towards the MRI findings in these pathologies. So without much ado, I'll start off with I'll ask Dr. Avi to start off with the first lecture. So Dr. Avi is my colleague at the SRC Children's Hospital. He is trained at various centers, including the Wadia Hospital, Sheffield Children's Hospital, and the Cincinnati Children's Hospital. And he is one of the very good hip preservation specialists who is operating in Mumbai as well as in various parts in the country. So Avi will be talking to you about the clinical examination and X-ray findings in hip preservation and in adolescent hip pathologies. So over to you, Avi. Avi, you are muted.
Your name. Okay.
Yeah. Is my screen seen yet?
Okay, 8:30 ಅಲ್ಲ. ಸರಿ ಇಲ್ಲ ಹೋದು.
So we have to share your screen.
I have. Is it seen now?
Yeah.
Yeah. May I request everyone else to mute their
I'll just mute it.
scenes till the time they want to ask a question. Yeah. Over to you, Avi.
Yeah. Just get my screen in order. Sorry about that. Yep. So hopefully my screen is visible now.
Yes.
And I'm audible. Yeah. Thank you so much for the kind introduction. So I'll just go through a little bit about the examination in a young adult hip and adolescent child. So as we know, diagnosis of hip pain can be quite tricky. We can get pain from the spine, the SI joint, from the abdomen, also near the hip joint. And as such, hip joint pain can be extra-articular and intra-articular. So we need to really find out with good clinical examination to help correlate it with all of our various radiological parameters. So clinical history, as with any examination, forms the basis. We need to have a good detailed medical history and family history of our patient. A lot of recent studies have shown that siblings of patients who already have FAI have 2.3 times the risk of having FAI, more so in males as compared to females. So a good history is really important. We need to know about all of their previous surgeries, if any, around the hip, previous hip problems, if they have had any, activity-related problems around their hip, especially when they are walking, sitting, or doing some form of sports. We need to know a lot of detail regarding their symptoms as to when it started, the duration, and any provocating factors. Always check for ligamentous laxity, as lot of girls especially have a high Beighton score, which could be one of the causes of their hip pain. So I would just want to put this out and won't go into detail. This is a newer concept known as the layer concept, which has been described in 2012. And this kind of helps us improve our understanding as to the interrelationship of all of these structures which are present around the hip. And this also helps us examine and understand the diagnosis that we are making. So overall, they have described 4 layers, and we need to understand the interrelationship of all of these layers so that we understand what we are treating. So there's just an example of the layer concept. If a person has FAI, so that's the osteochondral layer. Usually with that, they will have labral tear or injuries, which is the inert layer, which leads to flexor adductor sprains, which is the muscle component and the contractile layer, and can cause back pain. So there is an interrelationship between all of these structures, and we need to understand that, because most of our patients may just come to you with back pain, and you need to make sure that you're not missing out hip pathology. Now, the basic hip clinical examination, which you need to know for these kind of patients. So one is you need to check their stance and gait, inspect the hip and see where the pain and try to localize the pain, check the range of motion. Then certain impingement tests are there, and then we have certain additional tests to look for other pathologies. So the first step is always look at the stance and the gait. As soon as the patient comes to you, you see the patient in the standing position. You see how the patient, while standing, the position of the pelvis is. You see any leg length discrepancy. Check for the Trenberg sign to check for any abductor dysfunction. Look at the mechanical axis for any deviations like genuvalgum or varum type of deformities. Look at their gait. Are they walking with a limp? Is it with pain, without pain? Do you feel there is some neuromuscular condition going on, like a lurch and things like that? Then look at the position of the patella, if it is in-toeing or out-toeing. So this is the basic examination you start off with. Then you get into the general examination as you would do for any hip joint. Look for more for scars or any previous surgeries. So try to look for the pain. This is really important for us. Palpate near the greater trochanter, near the groin muscles, and the anterior and the posterior joint line. So this paper published by Cloyce in 2009 showed that 88% of this pain is localized in the groin, but can also present 35% in the anterior thigh, 27% in the knee, 19% in the lateral thigh, 67% near the trochanteric region, 23% may present just with low back pain, 29% near the gluteal or the buttock region, and 12% near the posterior thigh pain. Hence, hip pain can be localized in various regions, and we need to be really careful while examining. Also examine your patient in supine, in sitting position, and also see for pain in cross-leg sitting position, which is quite important for our Indian patients. So by at large, if you have a cam or a pincer or some amount of retroversion, usually you will have some amount of inguinal pain, which will be the localizing point. Excessive anteversion can be localized either in a gluteal type pain or an indirect inguinal pain. But this is not always true. So the nature of the pain is also really important. So piercing pain usually is associated with labral lesions and adhesions in the joint or loose bodies. Constant pain is usually associated with inflammatory conditions, arthritis, and can also be present in FAI conditions. Burning pain in inflammation or effusions of the joint. Rest pain, pain at startup, or pain after running is usually a sign of arthritis. A lot of these patients will have some form of radiating pain, as I've shown in the image before. And the C sign is a very classical sign when they come holding with a C around their hip. This is a very classical sign that you will see in a lot of these patients. Examining the range of motion is important. This is the basic average range of motion most of these patients should have, and deviation in range of motion or association with pain gives us that there is some pathology, either maybe intra-articular or extra-articular. So let's start with the internal rotation and external rotation in supine position. So you will check this in extension as well as in flexion. So in extension and flexion, if there is pain in rotations or any limitations, it tells us that there is some limitation either because of the asphericity of the head or there is some impingement going on. So internal rotation, usually when you check in flexion, if there is some limitation, there is usually a bony or a soft tissue component which may be associated, and it reduces with cam, pincers, and retroversion type of FAI, and can be more if you have excessive anteversion. Similarly, external rotation, when checked in the supine position in flexion, is usually limited by soft tissue. That is, either it can be if there's an implant or a bursa or the musculature associated with the external rotation. It increases with retroversion and reduces with excessive anteversion. Similarly, when we check our rotations in the prone position, internal rotation in the prone position, usually if there is a limitation, it is a soft tissue limitation, which and internal rotation can be reduced when there is excessive retroversion and can be increased if there is excessive anteversion. External rotation, when we check in the prone position, usually is limited either by a bony factor or a soft tissue factor, the bony factor being the greater trochanter, sometimes hitting on the ischium. It increases in retroversion and can be reduced if there is excessive anteversion. In prone position, by and large, in this age group, your normal finding that the rotation should be balanced on either side, usually 40 odd degrees on both sides. Then we come next to the impingement test. So there are few impingement tests. The first one is the anterior impingement test. So this test, when the patient is in supine position, you start from 30 degrees flexion and take it up to 90 degrees flexion, internal rotate and adduct the hip. So this test is actually a little bit of a misnomer. It is not actually checking for impingement, but it is more of a labral provocation test. Anything that irritates the labrum in this position, your patient will wins with pain. So a lot of studies have correlated labral regions with this test, and it has a positive predictive value of 100% and a negative predictive value of 13%. But it is a very good clinical test to pick up FAI. So this is how we do it. So you can see in a 3D reconstruction that when you flexed, adduct, and internal rotate, you can see the cam lesion is hitting the anterior part of the acetabulum and the labrum and irritating it, which causes the pain in our patient. The second impingement test is the posterior impingement test. So this is where your patient is in supine position. The hip is taken out of our examination table and is extended, and some amount of external rotation is given to the hip. So if there is any intra-articular pathology or a prominent posterior wall, your patient will complain of or have a sensation of pain. Or if it is an extra-articular pathology or impingement, like the lesser trochanter hitting the ischial tuberosity. So this is an apprehension test for anterior instability. So you can see one of these patients where they have a deep socket, a prominent posterior wall. So as soon as we do the test, you can see the head hitting the posterior wall and the labrum, and that is what causes pain. And if you continue do this, because there is anterior instability, the patient feels like the hip will come out. The third type of impingement test is only in pure flexion. So pain in pure flexion, usually in recent studies have been shown that it is associated if there is severe hip valgus. Also, it can be present if there is intra or extra-articular pathology. So always when you're checking for pure flexion, make sure you have stabilized the pelvis and you're not flexing the pelvis as well. And as soon as you flex, you may get a bony end feel or a soft tissue. If it's extra-articular, usually it is impingement with the anterior inferior iliac spine. And if it is intra-articular, it may be because of a prominent anterior wall, or there may be an anterior inferior asphericity in the femoral head. So like here, the first image, you can see there is some amount of coxa valga. And because of that, in just pure flexion, there is impingement at the level of the neck and at somewhat extraarticular at the greater trochanter. And in the lower image, there is a prominent anterior inferior iliac spine secondary to a fracture which has malunited. And in deep flexion, you can see the trochanter hitting the inferior spine, which is causing the impingement. The next impingement test is the Faber test, which is the flexion, abduction, external rotation test. This test is also used for examination the SI joint, which is also an important source of pain generator near this region. So usually when you flex, abduct, and gently external rotate, if you get a bony endpoint or feel, usually this denotes an extraarticular impingement of the greater trochanter to the ischial tuberosity, and is usually typically seen in patients who have excessive femoral anteversion. So you can see in the 3D reconstruction, when you do this maneuver, the greater trochanter hits the ischium, which causes the pain and the limitation. Then there are few other additional tests to pick up other pathologies. One is the Thomas test to pick up flexion deformities around the hip. The cycle test, as you can see in the first image, the patient is in the lateral position and you tell him to move his hip like he's riding a bicycle. This is to pick up the snapping iliotibial bands or any issues with the trochanteric bursitis. We also need to check the power of the abductor muscles in the lateral position against resistance. The psoas tendon test is a test where the patient is in a supine position and you abduct and first extend the hip, and then against resistance, tell him to flex the hip. So any issues with the psoas tendon, the patient will complain of pain in this maneuver. And then another test is the adductor squeeze test. You tell the patient to flex the hip and the knee and give a pillow between the knees and tell him to squeeze to check for the power. So these are in general the basic test which you would like to do in all of these patients. So this is a chart. I recently just visited Burn. So this is a chart which they have in their clinic walls to see what all examination points that they should do so that you do not miss at least these basic examination steps. So thank you so much. So that is for the examination. Should I continue or will we discuss right now?
I think we'll just have one question. I think Maulin has asked about indirect inguinal test, pain and posterior apprehension test. So these are two things we can just quickly answer.
Yeah. So indirect, so it is usually very difficult for a lot of these patients to localize. So basically the pain is in the either the posterior joint line or somewhere else, but the patient is complaining of pain in the groin. So it that is what I meant by the indirect inguinal region pain, because this pain, as I said, is referred in many regions. And the second question was regarding the posterior joint. So always we check the anterior femoral joint and the posterior joint. The posterior joint posteriorly, just near the PSIS, over there we check for tender points in the gluteal region. Sometimes it that can be the referred pain, as I said, in the gluteal region, or when we if there is a posterior pathology, then we'll pick up the tenderness over there.
I was just asking, is there any something like the posterior apprehension or posterior instability test also like an instability?
So there is a test. Don't do it regularly. It's clinically I don't know in literature how significant it is, because some of all of these tests which we do, all of them are not 100% like in other joints, because there are various causes of the apprehension. So like I did the posterior impingement test that tells us about the anterior apprehension. Doing a posterior apprehension is a little bit difficult. You can do it by flexing the hip and giving a posterior thrust, but it's usually not does not have a very what I would say it doesn't have high sensitivity.
Avi, I just want to comment on posterior apprehension.
Yes, sir. Please.
I do it routinely.
Okay.
With SLR, I do. When I do
Okay.
SLR all the way up, the hamstrings pull the head against the posterior labrum and acetabulum. If there's any concern about posterior superior dysplasia, that's one test right away. Second is
Okay.
whenever we're doing the anti-impingement test for FIR and adduction, that's automatically becomes a posterior apprehension if you push it hard enough.
Yes.
Right.
All
So,
right. Thank you.
and then of course, your questioning you can do it if you're still concerned.
All right.
Yeah, Avi, we can go ahead with the X-rays.
All right. Thank you. So I'll just start with the radiological evaluation in these patients. So as we know, imaging is very, very important for us in hip preservation because it adds on and gives us a lot of information. And we need to understand the proximal femur, the torsion, and the changes that have happened near the acetabulum and the relationship of all of these structures. So the diagnostic workup basically for hip preservation in regards to imaging, X-ray forms the main basic investigation. And then we also have MRI and CT scan. We have Dr. Daftary who will be talking about the MRI scans later. So in X-ray, a good AP pelvis and axial view X-ray is the first line modality in hip imaging and can give us a lot of information. But having a good X-ray is really important. So the acquisition techniques are also essential. So sometimes some of the pathologies that we see are normal, like cam morphology sometimes can be normal and is a normal variation in some individuals. So we need to understand first what is normal or ideal morphology, morphological variations, and sometimes every problem that we might pick up on the X-ray may not be the real problem the patient is having. So have a good AP view. There's a debate between supine versus standing view. Usually we get supine views, but in certain conditions, a standing view may be of more help. A supine view is has more control. It is more reproducible. So usually when you take a supine view, you have to be careful because sometimes there is an anterior pelvic tilt which can accentuate the version which you are seeing on the X-ray. And in standing as well, in standing, if it's not taken properly, you can have a posterior pelvic tilt. But most studies and literature usually have used the supine view, and this is what even I use on a regular basis. So as you can see here in supination and in standing, if it's the positioning is not done properly, you can have pelvic tilt, which will change all the parameters that you will see on the X-ray. So this is a supine and standing X-ray, and you can see the pelvic tilt changes with the position, and this is the same patient. There are other views which are important, such as the false profile view, the cross table lateral view, and the frog lateral view, which gives us other views of the hip joint, which are important for us. So an ideal radiograph should have no rotations, no tilt. The SC to the sacrocochlear joint to the sacrum distance should be around 2 to 3 centimeters in males and 2 to 6 centimeters in females. That is, we do not want any inlet or outlet views. It should be a properly centered beam, an ideal film tube distance, and have good exposure. So recent few articles and textbooks have also shown about the importance of film tube distance, and they say a too close a view can accentuate the retroversion. And also studies on fluoroscopy and IITV while doing PAOs have shown that the closer your IITV and your beam is to the hip joint, it can accentuate retroversion as well. So another thing is regarding the centering. The centering should be at the level of the SC joint, at the level of the acetabulum, because poor beam centering and low centered views can mask and change your version interpretation. So you can see the X-ray of a well-centered pelvis and a low-centered pelvis and of the same patient and how it changes the versional profile. Beware of even malrotation in different planes, as I said, inlet, outlet, and even in internal or external rotation of the hemipelvis. So because it changes the parameters of the things that we want to see on X-ray. So the basic parameters affected by malrotation are your anterior and posterior wall index, your crossover sign, posterior wall, and ischial spine sign. So that means it shows that malrotation mainly affects the way we interpret version on the X-ray. But our LCE angle, acetabular index, extrusion, and protrusion signs usually do not change with malrotation. So looking at a simple X-ray, we need to make sure there is no rotation, there is no tilt, no obliquity. Make sure all the bony outlines are well marked. That means it has a good exposure. So we need to see the iliac crest, the anterior superior iliac spine, the anterior inferior iliac spine, the ischial tuberosity, the greater trochanter, the lesser trochanter. This is the anterior wall. Then we should be clearly able to see the posterior wall, the iliopubic line, the ilioischial line, your teardrop, and the sourcil. So all 6 lines of lateral should be clearly visible. The anterior line is drawn when from the teardrop, if you just chase up right till the tip of the sourcil, that will be your anterior acetabular wall, and the posterior wall is drawn when you chase up the border along the ischial tuberosity, going up till the lateral edge of the acetabulum. So these are all the lines, and the interrelationship of all of these lines are quite important for us. We should also look at the soft tissues, look at the obturator fat pad, the iliopsoas fat pad, and gluteal fat pad, which sometimes let us know regarding inflammation regarding the hip joint. The acetabular depth is really important. So the hip joint normally is lateral to the ischial line. If our hip joint is just crossing this line, that means it is a coxa profunda type hip, and which tells us that the hip is a little bit deep. So if you see this, coxa profunda can also be a normal variant, but we need to look out for this. So here you will see the joint line or your teardrop is either on the line or has just crossed the line. Similarly, protrusio shows our hip is very deep. That means our the hip joint line is beyond the line which I just spoke about. So you can see over here, the hip is lying very deep, and this it gives us extreme over coverage. Again, the next thing we need to look at is the tonus angle. So the tonus angle is measured by its line and an angle which makes to the medial and the lateral end of the sourcil. So the acetabular inclination, anything less than 13 degrees is towards dysplasia. Normal is 0 to 12 degrees. And anything on the other end is a deep hip or going towards protrusion. Acetabular coverage, we look at the lateral center edge angle, the center of the head to midline, and angle to the tip of the the lateral edge of the acetabulum. Around 25 to 34 degrees is the normal angle that we need. Anything less than that is going towards dysplasia, and less than 20 is severe dysplasia. And if your angle is more, that is going towards a deep hip. A Sharp's angle can also be measured. It is a line with either you can join both the teardrops or both the ischial tuberosities and draw an angle to the edge of the acetabulum. So the normal is around 33 to 38 degrees. Joint space. It is important to check for the joint space, not only in one point, but at least in 3 points at the medial, lateral, and the center part of the sourcil, because it also is important to know at which part the joint space is reducing. Joint space minimal should be more than 2 millimeters, and anything less than that shows there is some pathology in reduction of the joint space. The anterior center edge angle is usually 25 to 45 degrees, but recent studies have shown that it does not have as much as value as our lateral central edge angle, but still it can be measured in the false profile view and gives us an idea of the amount of anterior dysplasia or uncoverage that we have. So the acetabular coverage, the anterior and the posterior coverage can be divided by the rule of thirds. So if once you draw your line, then the hip the head is divided into by thirds. So for the anterior wall and for the posterior wall, we divide the ball of the femoral head into thirds. So as you can see, in the red is for the anterior wall. When you divide it into thirds, then based on where your anterior wall comes, you can by and large say it is deficient, normal, or excessive. Similarly for the posterior wall. So this is an easy way to kind of get an idea of what kind of coverage you are looking at. So next we look at the version, and one of the important signs is the crossover sign, where the anterior and posterior wall crossover. Either it can be cranial, caudal, or complete crossing over. The posterior wall sign is an important sign for stability and retroversion. So normally the posterior wall will be just going through the center of the femoral head or just lateral to it. But if it is medial to it, that shows there is some insufficiency in the posterior wall, or there is a retroversion. Acetabular version index is another index which can be measured with kind of quantifies the amount of retroversion which you can have. So once you mark the crossover, you measure the amount of the crossing over is present to the distance of the entire wall, and you will get a retroversion index. A newer a neck axis deviation has also been described, and in this, if there is increased version, the distance will be more than 14 millimeters. And similarly, there is an ischial spine sign which shows a prominent ischial spine, which is also a soft indicator and marker of retroversion. So the ideal acetabulum should have a roof cover of average around 80%, anterior coverage of about 20%, posterior coverage of about 50%. Our version should be around 15 to 20 degrees. The sourcil should be concave and the angle around 0 to 10 degrees. We also need to check the roof length. Sometimes we can have a short sourcil or a flat roof, which is an indicative of having low volume or dysplasia. So based on this, we kind of get an idea of the coverage problems that we can have, either the normal coverage, under, over, or a complete global under or over coverage. So hip instability, there are signs on X-rays which can let us know about instability, and the Shenton's line is one of the most important and basic lines which we see. So if you have joint space reduction and subluxation, and we want to know what is actually the cause, is it the dysplasia which is the cause, or is there is an arthritis and there is a reduction in the joint space which is the main cause? So taking an abduction view will help in this. So if you see here in this X-ray, there is lateralization, reduction in joint space, and dysplasia. But once we take an abduction view, you can see the joint space actually is normal. The problem is mainly the subluxation. So this way we can differentiate between these two by taking an abduction view. A fear index has been recently described to help give an indicator of hip stability. So it is basically the acetabular inclination relative to the physial scar which is there. And based on that, it gives us an idea of stability and instability at the hip joint. It is a newer index and has so people are just talking about it. I don't use it regularly. Then there is the hip asphericity, which is seen in the AP view. So one is the sagging rope sign, which we see sometimes in our Perthes sequelae patients. You can see the line over there that it can be anterior or a posterior overhang of the head. Cliff sign was recently described in 2018 and denoted as a sign of microinstability. Basically, when you draw a circle around the femoral head, if there is flattening or reduced overhang on the lateral side, then they say there is microinstability at the hip joint. Similarly, for FAI, for CAM, you can see herniation pits or extension of the physial scar, which are soft signs to denote that CAM morphology or a CAM pathology is present in the patient. In the axial views, we check for the alpha angles and the offset, which lets us know regarding the CAM pathology. And an alpha angle should be more than at least 50 degrees and our offset around 8 millimeters. Torsion. Recently, lot of discussion has been going on regarding neck shaft angle and the torsional problems, which are the main problems which could be causing all of the pain and problems which we face while treating this pathology. So one is to draw the neck shaft angle. So neck shaft angle can change with rotation on your x-rays. So sometimes we just check the center of the femoral head to the tip of the greater trochanter, which can kind of give us an idea if we are seeing a coxa vara or a valga type of hip. The acetabular version as such cannot be seen on X-ray. We usually see that on CT scan. We check that with correlation with CT scan and our clinical examination. But as you see in this image, versional problems increases the risk of instability. I won't be talking about MRI, as Dr. Daftary will be going in detail regarding MRI. So basic overview of the imaging, as I said, conventional X-rays gives us a lot of information if taken in the right way. And if you systematically see it, you can see the acetabular depth, coverage, version, inclination. On the femoral side, the asphericity, the varus, valgus, head neck deformity. So, and if we need any more information, then we go on for CT and MRI imaging. So in summary, the beauty in these X-rays lies in the eyes of the beholder. It speaks 1,000 words. We need good views. Positioning is really, really important. We need to really assess the radiological anatomy, if it is a normal or a variant. And if at all we need any information, we do have higher imaging like CT and MRI, which adds on and gives us more details. Thank you so much.
Yeah, thanks, Avi. And Mandar, are you around? Okay, any questions for Avi?
Yes.
So these are really elaborative talk and a lot of science. But now sometimes, Avi, it becomes difficult to assess the anterior and posterior acetabular lines, to see the coverage. How should we?
So
It's easy to demarcate the posterior acetabular wall, but not
Yes.
the anterior wall. What to do for that?
So anterior wall, usually I say try to look for the teardrop, and usually when you go from the teardrop towards the lateral, so it's like a S shape. So from there, when you go towards it, that is where you will see the anterior wall. Yes, it is not easier said than done. But if you have a good exposed film and a good thing, you from the teardrop, if you start seeing, you can draw the line towards the lateral part of the acetabulum. That's where you'll see the anterior wall.
Right. So any comment? Mandar, I cannot hear you. Are you mute or something? Mandar, we cannot hear you.
So one question I want to ask is, how do you measure that the numbers were telling 2 millimeter, 3 millimeter in the X-ray? How do you calculate those numbers? The joint space regarding.
So basically, it's easier to do if you have a PAC system, and we have standardized X-rays. So on that, it is easy to measure this thing. But if you have a standardized radiograph, and you have your measurement factor there, you can measure it even on normal X-rays. But it's easier done if you have a PAC system on the computer, because the software helps us to do it easily.
How does the software know about how is your beam is placed? How far is the distance?
No, the software doesn't know about the beam and those things. That is
know, then how can you calculate the magnification?
No, so the magnification is already set in your X-ray machine software. So I'm not saying about the new software. So this is on the system itself. The beam centering and all is based on the training of what
my question is.
Can I help, sir? 1 second. So normally when we do an X-ray and you're looking for measurements, we'll have a standard marker that has got a standard measurement. So like a coin or something that has got a centimeter. And then you have that structure, you know what the measurement of that structure is. You place it right next to the patient when you take the X-ray. and then you use that as a reference to measure anything else.
Moulin, if you can't see the anterior wall on the X-ray, you need to repeat the X-ray. There are no tricks. Second thing is the 2 millimeter joint space RV.
Yes.
2 millimeters means it's too much arthritis. Less than 2 is a contraindication to do hip preservation. The normal space is not 2 millimeters.
It should be
2 is the minimum before we try to do preservation.
I meant to say it should be more than 2 millimeters, not 2 or less. Yeah.
No, but 2 is very narrow.
Yes. All right.
Gets to a place where it's contraindicated to do preservation.
Yeah.
Yeah. So thank you. I'm here on some another phone. So Avi, that was a great talk. We'll go to the next talk, which will be by Dr. Aditya Daftary. He is a musculoskeletal radiologist who is the chief radiologist at the Innovision Center for Radiology. He is basically the go-to man for any opinion about any musculoskeletal MRI finding, and he's a very good friend, and he has thankfully has said that he will be talking to us about all the MRI findings in adolescent hip pathologies. So Aditya, over to you.
Okay, thank you so much. Let me just share my screen. Okay, can everybody see my screen?
Yes, we can.
Great, thanks. So, and you can hear me fine.
Yep.
Okay, so I've actually just broadened the spectrum of this. I wasn't entirely sure that we were supposed to stick primarily to adolescent hips. But what I hope to give you in the next few minutes is an overview of how you can approach any pediatric hip for most of the common pediatric abnormalities. And so we'll go from a little bit younger all the way up, but I think this should help to build a decent understanding of how you would approach a pediatric hip. So to start with, I think I'm just going to look at a whole bunch of conditions that we do come across, from DDH to leg calf, Perthes, skiffy, idiopathic chondrolysis, infection, inflammation, bone dysplasia, synovitis and neoplasia, and FAI as well. So the first thing when you're looking at MRIs that I think everybody should be aware of is that we have three primary types of sequences. And in this, we're thinking about T1 weighted images, where if you think very simply about it, fat is bright and fluid is dark. If we think about a T2 weighted image, which is without fat saturation, both fat and fluid are bright. So think of 2, so both are bright. So fat and fluid are both bright in T2. In T1, only one is bright, which is the fat. And maybe you can remember, it's always easier, it's harder to get rid of fat than to get rid of fluid. So, remember that becomes easier. And then on a stir image, which is, or a T2 fat suppressed image, which is the sequence where we take a normal T2 image and we just blacken out all the fat so that all edema and everything like that becomes more evident to us. So these are the three sort of sequence types that you should remember and know about. Now, whenever we're approaching a hip MRI or any MRI for that matter, there are three sort of things that we want to consider if you were to go in a very basic sense. So one is you're going to look at the bone marrow edema. The second is you're going to look at the fluid. And the third is you're going to look at morphological or structural changes within different anatomy. So when it comes to bone marrow edema, we're trying to identify what the location of the bone marrow edema is, what the extent is, and what the severity is. When it comes to fluid, we're going to talk about the volume, the complexity, and the character. And then when it comes to morphology, we're going to talk about positional changes between structures, and we're going to talk about changes in shape of structures. So one of the things that we start out when we look at bone marrow edema is to try and identify where the bone marrow edema emanates from or where it starts from. And the first thing we'll talk about is epiphyseal bone marrow edema. So for example, here you have a young patient who has epiphyseal bone marrow edema at the superior aspect of the humeral head. And this is pretty classic for somebody you would see with potentially idiopathic chondrolysis. And I suspect this is the equivalent of what we see in an adult as a subchondral insufficiency fracture in today's day and age. This can lead to a little bit of collapse, and you can lead to sort of a stage 2 and stage 3 sort of idiopathic chondrolysis. And then this can look fairly similar to somebody who's got Perthes disease, where you can see flattening and deformity of the superior aspect of the femoral head. You can also see this, where you have a larger area of superior aspect femoral head deformity, which could be an osteochondritis dissecans lesion of the superior aspect of the femoral head. And then if it's bilateral, then you start to think about whether this is bilateral OCD lesions Or if you look really carefully at this person's bones, then what you'll start to notice is at the, on the spine, that there's deformity of the spinal bones as well. And this is actually of the vertebrae as well. And this is actually spondyloepiphyseal dysplasia. And then finally, when you start to see epiphyseal changes, when you start to see joint space narrowing, subchondral cystic changes, and you can see articular cartilage loss, then you start to question that you've reached the stage of osteoarthrosis. And in this situation, you're trying to understand if there's going to be more central migration of the hip. You're going to start thinking this is probably OA related to an inflammatory arthropathy. On the other hand, if you start to see uncovering of the hip, then you know this is the OA related to DDH. And if you see normal morphology, then it could be sort of a post-infectious OA. So this is sort of when you start to see epiphyseal bone marrow edema, how you can approach it, whether it comes with or without morphological abnormality. With physeal bone marrow edema, I think the thing that you need to be really careful about is when you start to see things like SCFE. Now, this example here is fairly obvious. You can see bone marrow edema along the metaphysis in the epiphysis, and you can see discrete angulation difference along the physis as well here. The sad part about this case is this case was seen about 6 months earlier by somebody else. And while you can see there's angulation difference and a little bit of this metaphyseal and periphyseal bone marrow edema, this was not called SCFE, and this was just called like some non-specific inflammatory disorder / infection. So it becomes very important for you to identify these bone marrow edema patterns and sort of see what you think about them. And I have no doubt that there was an X-ray at this point in time, and somebody probably blew by that at this time as well. When you start to see edema along the physis itself, the other thing you should think about, especially when there's scalloping of bone, is osteomyelitis. So here is an example of someone you can see bone marrow edema along the epiphysis with this sort of cystic lesion within the bone and adjacent bone marrow edema, and this is osteomyelitis in a young patient. When you start to see metaphyseal and apophyseal bone marrow edema, I think you've got to be careful again to start thinking about a variety of things. So this is a patient in whom you can see metaphyseal bone marrow edema, which you would potentially, if you saw this in an isolated location, start thinking about osteomyelitis. And this actually, when you have a multifocal appearance like this, which is either symmetric or asymmetric, we have to start thinking about inflammatory disorders of bone, such as CRMO or non-bacterial osteitis. Another sort of thing that we talk about is this thing called Van Neck-Odelberg syndrome, which is when you start to see bone marrow edema at the ischiopubic synchondrosis. And this can be stress related, or because it is also a physis, it can occur in association with inflammatory disorders of bone. If we see edema at enthesial or insertional sites, if we see them unilaterally in overload, obviously we think about avulsive stress, but it's pretty unusual to have bilateral avulsive stress. And when you start to see it bilaterally, you've got to think about enthesitis and in somebody possibly having inflammatory disease or inflammatory arthropathy. Another thing to remember is when you start to see bone marrow edema, always try and identify if this bone marrow edema is narrowing down to a particular point. And if you start to look at the T1 and T2 weighted images, you start to see that normally it narrows down to a point which sort of takes you to where the pathology is. And this is an example of a patient who had bone marrow edema in the neck. You can see this ovoid lesion here in the neck that it comes down to. You can see that there's increased sclerosis right around this, and this was all around an osteoid osteoma. So when you see unexplained meta or diaphyseal bone marrow edema, use T1 or T2 images to see where this bone marrow edema is tracking to. If it is not tracking to the femoral articular margin, then you've got to start thinking about osteoid osteomas. You can use CT because osteoid osteomas can be very subtle on MRI when they are small. And the second thing is early osteoid osteomas, especially if they are intra-articular, they don't show that characteristic sclerotic rim, and they don't have the same degree of sclerosis and bone remodeling that you would see in an extra-articular osteoid osteoma. So you might tend to miss these. Dynamic contrast MRI is something that you can consider. And then subtle stress fractures are a major differential consideration that you should think about. So let's say, for example, this patient who had excruciating hip pain, the X-ray looks bang normal. You look at a CT and you start to see maybe this is a small little osteoid osteoma. You look over here and you're still questioning whether this is a small little osteoid osteoma. You got an MRI and all you can see is a little bit of bone marrow edema, and maybe you're still concerned about whether this is an osteoid osteoma. And then you get a bone scan and you can see there's diffuse increased uptake here, which sort of confirms that all of that is in keeping with an osteoid osteoma. This is a patient that we had a few years ago. you can see that she had very classic symptoms of an osteoma. She would be in excruciating pain. You literally just dropped an NSAID into her mouth and her pain went away. And you looked at the CT and you can see these small little cystic areas and you're wondering, and there is bone marrow edema and these cystic areas are in close proximity to each other. And you're wondering which of these is the osteoma that you're going to ablate. And what you can see here is this posteriorly is just a little groove. So we merged the contrast MRI with the regular MRI. And you can see that this is actually the active lesion and this is not the active lesion. And then we went and ablated this active lesion and the patient got much better. So these can be very subtle to identify. Here's an example of someone you can see the bone marrow edema. If you looked at this, you might wonder if there's a little, osteoma sitting in here. And this actually turned out to be just a stress fracture. So when we think about bone marrow edema, when you're looking at these, think about things that are epiphyseal or subchondral. Remember that you can have them with normal contour or abnormal contour. Think about when you have bone marrow edema along the physis, the metaphysis/apophysis, and then you have metadiaphyseal bone marrow edema. The next thing you're going to start to look for is fluid. And when you look at fluid, you're going to start thinking about whether there is mild fluid or moderate fluid. You're going to start to characterize this fluid. This looks fairly bright and simple, as opposed to this fluid here where you can see synovial debris, and this is actually synovitis. This could be because of osteoarthritis that we have cartilage wear and tear in the joint, and that's what's giving you this kind of synovitis appearance. And then the last thing is when you see synovitis, look at the T1 weighted images, because if you see a bright T1 signal along the peripheral rim of the synovitis, then that's something that can help you to identify possibly tuberculosis or an infectious arthritis. So when you're looking at fluid, think about volume, whether it's mild, moderate, or marked. Think about the complexity, if it's simple fluid or if it's got debris and complexity inside it. And then look at specific characteristics. So if you see a discrete nodule, you've got to think about PVNS or a loose body. Most of the time you have X-rays, so look at those. Also, don't forget about those when you're looking at the MRI. If you have tiny, discrete, sort of homogeneous particles, think about synovial chondromatosis or rice bodies of an inflammatory disorder. If you have irregular, nodular, thickened, heterogeneous synovium, then you're thinking about synovitis, either from an infection or an inflammatory cause. And if you have a hyperintense T1 rim, then you're going to start to think about TB. DDH is another condition for which we often get MRIs done. And in this case, where most often, rather than making the diagnosis of DDH, which you've made on radiographs or ultrasound in the past, you're trying to determine whether there are potential things that could obstruct your reduction. Also, post-reduction, you're trying to see if by any chance, even though you've reduced them, those structures have come in the way. So here, for example, you can see this is sort of your, most of you are familiar with this anatomy, but you have sort of an inverted limbus here. And you can see here this inverted limbus getting in the way of this femoral head coming back into this acetabulum. You can have a situation where you have hypertrophy of the pulvinar fat, which you can see here, which would prevent this hip from coming back in here. You can see a situation here where anteriorly the iliopsoas tendon has subluxed into the joint, and that can be obstructing of of this process. And then last but not least, you can see posteriorly the labrum here that is that can obstruct reduction. When you have sort of over abducted, sometimes you may stretch the vascular structures, and obviously this can lead to avascular necrosis. And that's another thing that we can identify oftentimes with DDH. So on DDH issues with MR, I think you're trying to determine whether there's undercoverage. There's typically going to be undercoverage and labral hypertrophy. You're going to figure this out that the patient has DDH far more often on X-rays and ultrasound long before you do an MRI. When you're doing an MR, the primary reason you're doing an MRI is to look for any impediments prior to reduction. And then even once you've reduced the patient and you put them in a spica, and we've studied many of these as well, you're trying to see if something has gotten into the way of the reduction, which you may need to adjust. When we think about the degree of abduction, if you have too little, obviously you get redislocation. And if you have too much, then you're prone to AVN, which we can pick up on MR. Now, coming to the point of major discussion, it's the femoroacetabular impingement. Now, I know that I'll get beaten up by many people in this audience about a variety of different things, but honestly, I think the only thing I can drive home is just please be very, very careful when you're talking about FAI and when you're managing these patients. It is a condition that is fraught with a lot of controversy amongst some and less amongst others. And I'll show you some stuff. So what I'm going to start out with just talking about how we would go about looking at FAI on MR or on imaging. I think what you have to think about here is there are three primary patterns of FAI that we look at when we're looking at purely bone. So as mentioned previously, FAI is a multifactorial entity. We tend to simplify it to some extent by talking about as two bony structures, but it does involve capsule, it involves muscle, it involves neuromuscular control, it involves a whole bunch of different things. The primary issue here is, for whatever reason, there is impingement between the femoral head and the acetabulum. Now at here, you can be, the femoral head and neck junction can be at fault by being sort of more prominent. There is an old school of thought that there is some element of a subclinical skiffy that may have resulted in this, and therefore you see this prominence. There are a lot of people who talk about pits or the anterior intraosseous cystic change that happens here. It's very easy to say that this is a soft sign associated with FAI, but the truth of the matter is we see intraosseous cysts in people who have absolutely no FAI as well. So it's really not a great indicator or something that you should jump at every time you say cyst, you start thinking FAI. So I just want to dispel that myth a bit. The second thing is what we're trying to do in this situation is we're trying to determine if there is actually bony prominence here. This prominence can be anterior, it can be more superior also. The second type is where we start to see overgrowth, or you see bony overgrowth of the acetabulum for a variety of reasons, or you see abnormal version of the acetabulum, which can lead to impingement. And the third option is where you start to see a combination of both. You see a little bit of femoral sided change and a little bit of acetabular sided change. So these are sort of the areas that we're going to look at. Now, when we look at radiographs, I think you've seen this is sort of the normal femoral head neck junction. And here you can see a subtle, more prominent femoral head neck junction. And if I were to just sort of show this to you, if you were to look at this like this, you can see there's a nice bumpy step off here. So this sort of S sort of appearance, whereas this looks sort of more straight and you don't have that S. So this is much, more curvaceous, if you will, and this is much flatter, if you will. And so this is sort of one of your signs of a CAM type of femoral acetabular impingement. And on MR, you'll see the same thing. If you follow this, you can see it sort of having this curvaceous appearance and this having a much shallower curve, showing you that this is more prominent bony bump here. Traditionally, we measure this using an alpha angle. So what you do is you try to get to the center point across the femoral neck like this. You get an axial image at that level. You draw a best fit circle around the femoral head. And then you draw an angle that goes from the greater trochanter to the center of the femoral head. And then you see where this circle and this bone part ways. All right. Now, if this circle and this bone part ways more superiorly or more wider, then you know that there is a bigger bony bump here. And therefore, this alpha angle will be wider. Typically, the cutoff that everybody uses is somewhere in the range of 55 degrees. And again, one of the things that I drive home to everybody, we say constantly in radiology that there is nothing more dangerous than a radiologist with a ruler. And I do believe that there is one thing that is more dangerous, and that could be an orthopedic surgeon with a ruler, because we'll just report and tell you something. You might actually act on it. So I will say just exercise a lot of caution before you take these measurements and start jumping all over things. It takes a lot of experience. Most of the speakers that you're going to hear here are very, very experienced. And I can guarantee you that they don't all go just by numbers. So just please take that as a huge, huge, huge thing about before you start jumping into things based on numbers. Remember, there's a lot more that goes into it. So the alpha angle is something that helps to determine whether there is an offset from the femoral head neck junction, whether there's a bony prominence, and then whether that is going to result in a bony bump, possibly causing impingement. The secondary things that tend to happen with it, you can start to see labral tears or labral degeneration. You can see paralabral cysts forming with it. You can see intraosseous cystic changes and articular cartilage changes in the anterior superior labrum. And all of these things together form the compendium of what we would consider FAI on imaging. The crossover sign is something that was already discussed. You can see that normally the crossover tends to happen at the mid portion of the acetabulum. And in some cases, when it happens more proximally, that's when you start to think of somebody having an abnormal retroversion or anteversion of that acetabular cup. On MR, we can obviously use the interischial line and we can measure the degree of version of the acetabular cup in relation to the normal side, or in general to normal variants. Some of the other things that we look at, we can oftentimes see that there will be a large os acetabulum, or we can see this large bony bump here that could lead to a pincer type impingement. So you can see either abnormal rotation, or you can actually see bony prominence that can lead to impingement. You can have a mixed situation here where you can see this acetabular prominence, so this acetabular offset, and you can see here a bony prominence as well. So you have both things happening simultaneously. So what is the spectrum of things that we can see on MRI? We can see a normal, proper S-shaped thing here. We can see a flattened S here in somebody who has a cam lesion. We can see a big bony prominence here in somebody who has a pincer lesion. And you may see a combination of this bony prominence here, as well as this bony prominence here, that could lead to impingement. So now what does all of this mean? We actually did a study. This was a few years ago with Dr. Pachure with ISHS, which is the Indian, the Hip and Knee Surgeon Society. And we looked at, across multiple centers in the country, 904 asymptomatic hip X-rays. So these patients were clinically diagnosed as not having FAI. And we broke up the abnormalities into those who had acetabular rotational abnormalities by X-ray, those who had acetabular overcoverage by X-ray, and those who had femoral bumps. And we divided these into those that had one abnormality, two abnormalities, or three abnormalities. And we found that a huge number of patients had these abnormalities. So these are clinically asymptomatic patients examined by orthopedic surgeons who have all the radiologic signs of impingement, but do not have any signs of impingement. And these are already adult patients. So I think this is something just that I like to drive home, just to say that, please, we should be very careful with this. In the regular world of post-adolescent, so in the 20s and 30s age group, there was a huge wave of doing surgery for FAI, maybe about 10, 12 years ago, and that has shrunk significantly to the best of my knowledge. So in 2016, actually, because of all this rampant FAI surgery, there was the Warwick Agreement. They went through sort of defining what FAI is, the symptoms of FAI, how it should be diagnosed, what the role of imaging is, what is the appropriate treatment for FAI, prognosis, how to manage these situations. They've gone through a lot of these things and basically shown it's multifactorial. There's a bunch of different things, and it's not always that surgery is the answer. So what I just wanted to drive home in all of this is, first of all, I wanted to give all of you an approach to how to look at a hip MRI, to understand bone marrow edema and how you can make it your friend. Learn to evaluate fluid. It's not 100%, but it gives you a lot of clues on how to approach disease. We talked about DDH, identifying it, identifying the impediments to it, and the complications of DDH and reduction surgery. And if I'm to drive home nothing else today, it's to say that, that FAI, yes, there are great imaging tools available. It's the easiest and most objective thing that we have available to us. We can just take an X-ray and say, well, this line is here, that's it. Unfortunately, there's a lot of subjectivity within that also, but more importantly, there's a lot of subjectivity in the clinical examination as well. And I would just, we have historical data that shows that all patients with radiological findings of FAI do not have FAI. We have historical data that people who did a lot of FAI surgery are doing much less now than they ever did before. So while yes, it's a real entity, it's a problem, don't jump to surgery straight off the bat. And it really requires a far more experienced and nuanced approach than just looking at a bunch of X-rays and MRIs and starting to make calls on whether you should do surgery or not. So what I've tried to do here is overview some of the common entities, what the common things that we see with them are, and sort of how you can approach using those in your practice. So thank you.
Thank you, Dr. Aditya. I'll just take over from Mandar, who's just washed into a case. I just wanted to ask you now, there's always a debate, is arthro MRI much more better for FAI, and your take on what everyone nowadays talks about, these radial sequences, which they say which are better for the FAI in MRI. What is your take on that?
Look, I mean, I think I always put this to orthopedic surgeons in a very simple way. Is that what's your favorite test to diagnose FAI? Like clinically, what's your favorite test? And you go to 15 different orthopods and they all have 15 different favorite tests. And it's the same thing for us. It's a question of, I think the issue here is of a few things. One is, I've never had to do an arthrogram to look for a labral tear. There are people who, prefer to look at arthrograms. They think it gives them more information. Frankly, where I trained at Hospital for Special Surgery, and we never did them, and we're very good with diagnosing labral tears on MR. I don't think that's much of an issue for us. The second thing, as far as bony bumps go, yes, there are some people who are more interested. It's sort of a little bit of a, what does the surgeon want, or what does the surgeon you're dealing with want? There are some surgeons who say, I want these radial cuts because it actually allows me to understand better what I'm doing and how I'm doing it. There are others who say that, listen, I just need to know if there's a bump or not. I've got pretty strong clinical signs of that there's there. I've got a radiograph that shows it at well. And I'm anyways going to go in and shave off some of the bone intra-articularly, and I'm going to keep checking. So my getting too much more additional information, not changing anything. So yes, there are certain people who want a lot of things. There are some who will go minimalistic, and generally speaking, what I'll find is that, and I know Prasad is dying to jump in here, is I find that generally speaking, what I find is the more experienced surgeons don't need that much information.
So one question to the clinicians or hip preservation surgeons, Prasad and Avi, what are your indications of asking for an MRI in a clinically proven case of FAI?
Prasad, sir, you want to say first?
No, go ahead.
So I as a routine protocol usually ask for an MRI because it's not just about the FAI. You might miss other things in the hip as well. So normally the screening MRI, it can pick up other things like SI joint problems, this, that. So it's, as a routine protocol, I usually try and get an MRI done. But if it is a clear-cut clinical, everything is there, then maybe MRI may not be, but most, I think, although whoever I speak to and this thing, as a protocol, they used to get an MRI done for all the patients. I think Prasad sir has, has a different thought on that, so I'll wait him for to answer.
All right. First of all, Aditya, great talk. Thanks for emphasizing that MRI and X-ray are not diagnostic of FAI unless you see classic damage. That's actually too late. By the time you see all the cysts, labral tear and all that, there's a lot of damage happens. FAI is a clinical diagnosis. Labral tear is not really a diagnosis for us. We need to figure out what's causing the labral tear. So that's my two things about MRI. When do I get an MRI? MRI for me, I got MRI in every FAI surgery I did in the first, say, 5 years. And I got only one non-FAI diagnosis. Then I stopped getting MRI scans. Then I got one complication. I got sued and I lost that case because I didn't get a pre-op MRI. But now there is enough literature in orthopedics saying that MRI is unnecessary for FAI, right? But in India, I'm not able to rule out bone marrow edema and AVN on clinical exam in a lot of people. A lot of people have FAI clinical diagnosis by me. I get an MRI and they show some AVN or some bone marrow edema. It's much more common. So MRI is a must preoperatively to rule out other pathology. It does not confirm FAI for me. Seeing a labral tear is not important for me, but it's very important to rule out some of the pathologies that I'm missing clinically. So that's my take on when I get an MRI. But yeah, MRI is not a standard in America anymore, preoperatively.
I not just because that's my job, I tend to agree with that. I just think because there is a lot of bias when, especially younger orthopods are looking at things. And I think you should cover yourself when you're getting into surgery, especially in your early days of surgery, to be very comfortable that you're not missing anything. It's also a good way to ensure, from a patient perspective, that look, we've done all the due diligence before we've gone to surgery. And I think it's just sort of, otherwise you just go down. And we've seen enough patients where somebody will try to do something thinking clinically it's X, and it turns out to be something completely different. And you're like, well, I mean, what on earth could have, and especially with the cost of things, with everything else, what on earth would have prevented you from just doing that one more step of due diligence before you jumped right in?
The issue is, it ends up as a double-edged sword at times, as we have kind of undertrained orthopedicians, we also see some undertrained radiologists. And some of them are over-reporting things. For instance, a transient synovitis due to the quantity of fluid on MRI would be reported as septic or infective pathology.
Sure.
And it becomes as you know, for surgeons, it becomes more time consuming to tell that you don't need a surgery than to need a surgery. So sometimes that's a problem. But what I feel is just like Aditya, all orthopedicians who are dealing with it must learn how to read an MRI. For infections, we do not see the report because we know how to read MRIs. And sometimes we have to correct our radiology colleagues. So through these lectures and both the talks, I hope all the fellows would learn how to see and how to approach an MRI. You know?
Look, I agree with this completely. All I'm trying to say is that also, one is we have this tendency, everyone has to learn this and everyone has to learn that. But I think the more important take-home message is everybody has to talk to each other. You can't say that. I mean, if there is something where somebody calls, and I can't also emphasize the amount of conversations that we deal with, that at least I hear from my radiology colleagues, who they deal with some orthopedic surgeons who calls and just constantly berates them, as opposed to having a conversation, and also gives no information whatsoever prior to anything. Just throw an MRI hip pain, bus. That's the only thing you get. You come back, why can't you give me a diagnosis? Why can't you do this? Why can't you do that? I mean, that's just, it's an unreal expectation. And I think if there's better communication, better conversation, you will not only find that you're getting much more, I mean, just think about it. And I'm not trying to say, some of the smartest physicians who train out of our medical programs are going into radiology. They're not stupid people. They have just very limited amounts of information that they're dealing with, and they're doing the best they possibly can with that. They're also reading a large number of studies in a day. And I think there's just a simple conversation can make a massive difference. And it will learn, and you will build great allies in radiology just from doing this. And you will get much better reports. You'll get much more comfortable. And the amount of information that you'll get, which when you're looking at MRIs that you miss, will be incredible. And you'll learn a lot more also from that.
Yeah, I agree with that. And that also will be one of the coming topic is an orthopatho radio meet about infection. After this hip symposium, we are going to do that. So I agree, Aditya, on that communication is a key. So Avi, if we do not have a question, we would conclude. And yes. I thank everyone.
Yes. One thing. Yeah. I just want to answer Avi. The radial sequences are really important if you really care about the alpha angle. What I've seen is the cam bump I see on an X-ray not being seen or reported on the regular MRI.
Yes.
So a radial cuts is when you can get 360, not 360, but at least 18 measurement, 10 degree, whatever sequences, you can get your alpha angle. If you really care about alpha angle measurement, then a radial sequence become important.
So just about that, more than alpha angle, sometimes I've picked up the cam which has not been seen on the other. So just it gives a more view. That's just an additional thing.
Yes, so it allows you to basically play around with the data a little bit more. And what we've generally found, what many imaging centers don't do in the hip, is they give you straight axial, straight coronal, and straight sagittal images of the femoral neck. What we generally tend to do in our practice is when we get small field of view, so we do a dedicated coronal, and axials to look for main, all over hip pathology. But then when we're looking at smaller field images of the hip, we will tend to get oblique axial and oblique sagittal images that go along the femoral neck. So that's sort of equivalent to what you might get, similar to what you might get on a radio. So you can look at bumps in multiple directions of that. So yes, that's something. And I think that's the other thing that happens. Most centers and most orthopedic surgeons have a tendency to write MRI PDH. So you think a patient is going into the scanner, so you should scan both hips and you can get everything from that. But if you ask for a specific hip and you say, I want small field of view images from that hip, then you get more focused images with appropriate angles. And you can ask for, like MRI of the right hip or left hip with oblique axials through the femoral neck. So then that gives you a much clearer image and you'll be able to identify those things much better.
Thank you.
All right. Great. Thanks, everybody.
Thank you.
All right, guys. Good night for me.
Thank you so much.
I said good night for me. I need to go to sleep.
Yes.
Beyond my bedtime. Good night.
Good night, brother.
So thank you very much, everyone. And with this, the basics of FAI and the hip preservation. Next week, we will come and talk about surgeries. And a week later, Dr. Prasad will share his experience in India and abroad. So I look forward to the next week's meeting. Aditya, thanks for your time. I might disturb you. I might ask your help in our forthcoming fellows rounds when we are doing this
Anytime.
ortho radio meet. Okay.
Anytime. And I think you asked for the this thing on. I'm just putting the link to the Warwick agreement at the bottom here also, since you asked for it. So at least a link to.
Yeah.
where you
So,
can,
Dr.
so that's
Godha, can you download and share in the fellow?
It's already there.
Thank you. Thanks.
All right. Great. Okay.
Thanks, Avi.
Yeah.
Take care.
Thank you. Bye.